Welcome to another edition of Paramedic Student Medical Emergency Review. In this section, we will cover urology and nephrology, disorders of the urinary system, and the kidneys. All of the information that we will be covering is adapted from the Paramedic National Educational Standards. As a paramedic student preparing for entry-level paramedic work, you should have a good understanding and a good grasp of the genitourinary system, the function of the urinary system, and the general anatomy. The general anatomy includes the structure of the kidneys, the ureters, the bladder, and the urethra. Also, the structure and the function of the functional unit of the kidney called the nephron. Functions of the urinary system include regulating water and electrolytes, regulating acid-base, excreting waste products and foreign chemicals, regulating arterial blood pressure, producing red blood cells, and producing glucose. In order to specifically understand each one of the conditions that will be discussed in this lecture, you do need to have a good grasp of the anatomy and physiology. To understand what's not right, you must understand how something functions normally. If you do not feel that as a paramedic student you have a good grasp of the renal system and the urinary system, you should definitely go back to the anatomy and physiology chapter and refer to the section that covers the kidney and the urinary system. Moving forward, specific genitourinary and renal disorders that will be discussed in this section include acute renal failure or acute kidney injury, chronic renal failure, causes of acute renal failure, which include prerenal causes, renal causes or intrarenal causes, and postrenal causes. We will also discuss dialysis, urinary retention, urinary tract infection, renal calculi, acid-base disturbances, fluid and electrolyte disturbances. Other topics that will be discussed during this time is a brief discussion on the male genitourinary system and disorders and injury that could occur with that. So to start the discussion, let's talk a minute about acute kidney injury. Acute kidney injury also could be referred to as acute renal failure. This is a sudden drop in urine output that is less than 400 to 500 milliliters a day. This is due to a sudden decrease in filtration through the glomeruli, which causes toxins to accumulate in the blood. This loss of function may occur over several days, and it's most often secondary to another disease process. So acute kidney injury is typically secondary to another cause. Up to 20% of critically ill patients develop acute kidney injury, and mortality for these patients may be as high as 70%. Patients may experience generalized edema, acid buildup, and high levels of nitrogenous and metabolic waste in the blood. It can be life-threatening, and if untreated, it can lead to volume overload, hyperkalemia, uremia, and metabolic acidosis. There's three types of acute kidney injury, or three causes of acute kidney injury. This includes prerenal, intrarenal, and postrenal. Prerenal acute kidney injury is caused by hypoperfusion of the kidneys. Most often the common causes are going to be hypovolemia, trauma, shock, sepsis, and heart failure. If hypoperfusion is prolonged or worsens, the glomerular filtration rate decreases, and less filtrate means less urine is formed, causing nephron tubular cells to become ischemic and active reabsorption and secretion to flow or stop altogether. Intrarenal or renal acute renal failure is caused within the kidney or the renal parenchyma. Microangiopathy and glomerular injury result in obstruction of the minute vessels that are a vital part of the blood vessel tubule structure of the nephron. Tubular death or acute tubular necrosis can follow. Interstitial nephritis, a chronic inflammatory process caused by toxic compounds, can also result in acute renal failure. Of note, tubule damage can also be caused by hypoperfusion leading to the acute tubular necrosis or toxins, or rhabdomyolysis, which is the released myoglobulin within the body system, and it damages the tubules. Postrenal acute kidney injury is caused by obstruction or urine flow from the kidneys. The source of the obstruction is often a blockage of the urethra by an enlarged prostate in men, kidney stones, blood clots, or strictures or narrowing of the ureters. The blockage raises pressure in the nephrons, eventually shutting them down. It's very important to remember that all forms of acute kidney injury lead to the inability of the kidneys to carry out their cleansing functions, which may lead to the development of hyperkalemia, metabolic acidosis, and uremia. These conditions are life-threatening and can lead to fatal cardiac dysrhythmias secondary to hyperkalemia and acidosis, hypotension secondary to acidosis, and mental status changes secondary to uremia. The presentation of a patient will vary depending on the cause. Patients with prerenal acute kidney injury often present with dehydration, signs of shock, decreased urine output or darkening of the urine, and flank pain. In postrenal patients, pain in the suprapubic area related to bladder distension or in the penis from obstruction. And the most severe cases may present with altered mental status or signs of heart failure. Because acute renal failure can lead to life-threatening metabolic derangements, monitoring of the ABCs is vital. Initial fluid resuscitation may be required if hypovolemia is present. Monitor ECG readings closely and adjust support per local protocol. Of particular note with the ECG, you should be looking for tall spiked T waves, which is going to indicate hyperkalemia. Chief prevention strategies are protecting fluid volume and cardiovascular function, as well as eliminating or reducing exposure to nephrotoxic agents or medications. Chronic kidney disease or chronic renal failure is the inadequate kidney function caused by the permanent loss of nephrons. The four pathologic processes that initiate nephron damage of chronic renal failure are the same as those underlying acute renal failure: microangiopathy, glomerular capillary injury, tubular cell injury, and inflammation or infection in interstitial tissue. One of the big differences that you should know is that acute renal failure is often reversible. Chronic kidney disease or chronic renal failure is not reversible. There's over 468,000 people in the United States who are on long-term dialysis now. In the population 65 and older, the incidence of chronic kidney disease is growing rapidly, and it actually doubled from the years 2000 to 2008. This is a progressive and irreversible inadequate kidney function that develops over months or years. More than half of all cases are a consequence of systemic disease, but it can also be caused by congenital disorders or prolonged pyelonephritis. One of the observations that I've made over my years in health working on the ambulance and working as a nurse is that many causes or many cases of chronic renal failure that leads to end-stage renal disease is often due to untreated or poorly treated diabetes, poorly treated hypertension. I've often called it the triad when I'm teaching. Many of your patients are often going to have diabetes, hypertension, and renal disease. As the disease progresses, scarring occurs as the damaged nephrons cease to function. Then the tissue shrinks and wastes away, leading to a loss of nephrons and renal mass. As waste products and fluid build up in the blood, the kidney function continues to diminish. Patients will then begin to experience uremia, which is increased concentration of urea and other waste products in the blood, and azotemia, which is increased level of nitrogen waste in the blood. Systematic complications are going to include hypertension, heart failure, anemia, and electrolyte imbalances. During the focused history and exam of these patients, you'll probably find many characteristics of uremia in chronic renal failure patients and end-stage disease. The focused history will typically show GI symptoms such as anorexia and nausea, sometimes vomiting. You may see pale, moist, cool skin, and even a condition called uremic frost, which appears when excessive amounts of urea are eliminated through sweat. Hypotension or hypertension may occur depending on the degree of fluid retention, and ECG findings may include arrhythmia secondary to hyperkalemia. Metabolic acidosis compounds these effects. Your abdominal exam may reveal many abnormalities, and the challenge is to begin separating chronic findings and those of recent onset. So your immediate management is going to be the same as with other patients. Supporting ABCs, oxygenation, prevention strategies or regulation of fluid volume and cardiovascular function, and elimination of exposure to nephrotoxic agents or medications. Err on the side of conservative treatment except for clearly life-threatening complications. Be very judicious and very careful with drug administration as well. End-stage renal disease is going to be the next step past chronic renal disease, and it's going to result of untreated acute or chronic kidney disease. And at this point, the kidneys have lost all ability to function, and the only treatment for this, there is no reversing of this. The only treatment is going to be dialysis or a kidney transplant. Renal dialysis is a technique for filtering the blood of its toxic waste. It removes excess fluid and it restores the normal balance of electrolytes. You've got two types of renal dialysis. You've got peritoneal dialysis and hemodialysis. Peritoneal dialysis is a treatment in which large amounts of specially formulated dialysis fluids are infused into and then drained from the abdominal cavity. The fluid will remain in the cavity for 1 to 2 hours, and then it will be drained out and thus has filtered the body. It's effective but carries a high risk of peritonitis or infection in the abdominal wall. Aseptic technique is essential. This is a good option for people who want to do this in home. Hemodialysis includes a trip to the dialysis center 3 times a week, and the patient's blood circulates through a dialysis machine that functions much like the normal kidneys. And so essentially the blood goes in and it becomes filtered and then it goes out. There is a big risk with electrolyte imbalance with these patients and also fluid imbalances with these patients as well. In order to perform renal dialysis, you've got to have access, and there's 2 types of access. This includes a fistula or a graft. Not a graft, but a graft. A fistula is a surgically created connection between an artery and a vein, usually in the arm, for dialysis access. An arteriovenous graft is a surgical connection between an artery and a vein. Moving on, let's talk a few minutes about urinary obstruction and incontinence. Urinary retention is the incomplete emptying of the bladder or inability to empty the bladder. There are several conditions that cause urinary retention: kidney stones or renal calculi, acute kidney injury, BPH or benign prostate hypertrophy, urethral obstructions, UTIs, and nerve damage. Patients with these conditions may present with extreme discomfort and should be transported to the nearest facility for urinary catheter placement. On the flip side of that, urinary incontinence is loss of bladder control. There's 2 types if it's a medical problem: urge incontinence or overflow incontinence. Urge incontinence is a sudden intense urge to urinate with involuntary urine loss occurring within seconds or minutes. And overflow incontinence is a constant, continual, slow flow of urine. And if you're incontinent, then you're in a lot of trouble. There's many potential medical causes, including UTIs, medications, bladder irritants, bowel conditions, Parkinson's disease, Alzheimer's disease, stroke, certain cancers of the uterus and the urinary system, and nervous system damage associated with multiple sclerosis. Urinary tract infections. UTIs are characterized by their location as upper or lower UTIs. Urethritis affects the urethra and is typically coupled with cystitis. Cystitis is an infection of the bladder. Prostatitis involves inflammation of the prostate gland, and pyelonephritis is an infection of the renal parenchyma, which includes the nephrons, interstitial tissues, or both, and is an upper UTI. Community-acquired infections are predominantly gram-negative bacteria, and there is a high incidence of nosocomial or hospital-acquired infections related to urinary catheterization. A focused history centers on painful urination. Asks the patient questions about their urinary habits and signs and symptoms when they urinate, such as painful urination, frequent urge to urinate, or a difficulty in beginning and continuing to void. Pain begins as visceral discomfort and progresses to severe burning during and just after urination. Pain is localized to the pelvis. However, patients with pyelonephritis are more likely to feel generally ill or feverish and complain of constant moderate or severe flank pain. Patient often appears restless and uncomfortable, and the vital signs will vary with the degree of illness and pain. Another thing to remember is that there are some neurological effects with urinary tract infections, often with the older population. UTI management should center on the ABCs and circulatory support, analgesia for severe pain, and hydration to increase blood flow and to produce a more dilute urine, which is going to be accomplished through IV therapy. In-hospital treatment or post-diagnosis treatment is going to require antibiotics. Kidney stones or renal calculi. Stones may form in metabolic disorders such as gout and primary hypothyroidism, which produce excessive amounts of uric acid and calcium. Most often they occur when the general balance between water conservation and dissolution of relatively insoluble substances such as mineral ions and uric acid is lost, and excessive amounts of the insolubles aggregate into stones. Kidney stones are extremely common and they originate in the renal pelvis. Roughly 1 in 11 people will experience a kidney stone in the United States. Men are more affected more often than women, and risk factors include diet, hydration, personal or family history of kidney stones, and hypertension. There's a couple of types of kidney stones, which include calcium stones. They are the most common: calcium oxalate and calcium phosphate stones. They also may have a hereditary component as well. They may form when the concentration of calcium oxalate or phosphate becomes too high in the urine. Struvite stones are more common in women than men and may be associated with chronic UTI or frequent catheterization. Uric acid stones are more common in those with a history of gout, and cystine stones are associated with a condition that causes large amounts of amino acids and proteins to be excreted in the urine. Patients almost always experience pain, especially flank tenderness. Patients may often present with hematuria, vague discomfort that progresses to intense pain within 30 to 60 minutes. In my experience, I have found that pain control is absolutely needed, but I have found that Toradol actually works pretty well in these patients. If you don't have Toradol, a opiate is definitely a consideration as well. As always, management begins with ABCs. Position of comfort is very important. Be prepared for vomiting due to severe pain, analgesia en route. Nausea and vomiting are common and antiemetics should be considered, and if kidney function is adequate, IV fluid promotes urine formation and movement through the system. Now we're going to just quickly talk about specific disorders with the male reproductive system. This is going to include trauma, epididymitis or orchitis, Fournier's gangrene, and some structural considerations as well. Epididymitis is an infection that causes inflammation of the epididymis along the posterior border of the testes. Orchitis is when one or both testes become infected. Infection causes one or both testes to become enlarged and tender, results in pain and swelling in the scrotum. Swelling may occur in the groin on the affected side. The pain may decrease during bowel movements, and the patient will frequently have a fever and urine with a foul odor. Again, if your urine has a foul odor, then you're in trouble. Pre-hospital management is supportive. Consider, for the fellow's sake, administering analgesics. Fournier's gangrene results from bacteria entering the scrotum or the perineum, often from a small abscess or an open wound. Causes necrosis of the subcutaneous tissue and muscle in the scrotum. The patient will be febrile and may even become septic. The scrotum and the perineum will be tender, warm, and red. Purulent drainage may be present, and if unchecked, scrotal tissues will become gray and black. This is a true emergency, and prompt transport to the hospital is required. The patient is going to rapidly become septic, and they'll need aggressive treatment with IV fluids, and then in hospital they will need antibiotics and possible surgical intervention. A couple of structural conditions: phimosis or paraphimosis. Phimosis is the inability to retract the distal foreskin over the gland's penis. Paraphimosis results when the foreskin is retracted over the gland's penis and becomes entrapped. This is a true emergency. Failure to relieve the paraphimosis can result in necrosis of the glands. Priapism is going to be a painful, tender, persistent erection. Several different causes. I know that in EMT school you learn one of the main causes is spinal cord injury, but there are several common causes such as sickle cell disease. Certain medications such as antidepressants, anticonvulsants, and those used to treat ED. Don't make assumptions about the condition's cause. Treat the patient with respect and administer analgesics. And of course, you want to ensure proper immobilization if spinal cord injury is suspected. BPH, or benign prostate hypertrophy, age-related, non-malignant, or non-cancerous enlargement of the prostate gland, occurs in 50% of men older than 50 years and continues to increase with age. May be asymptomatic or may lead to difficulty starting urine flow, slow, weak urine flow once started, incomplete emptying of the bladder, or increased urination at night. Testicular masses rarely require pre-hospital treatment. Most are benign cystic masses or a varicose, massive dilated veins posterior to the testicle. Testicular cancer usually presents as a painless solid lump on the testicle. And finally, testicular torsion. This is going to be twisting of the testicle on the spermatic cord from which it is suspending. It's going to be extremely painful, and it is a medical emergency because it reduces blood flow to the testes and they become ischemic. Allow the patient to assume a position of comfort, and please provide analgesics for pain control if necessary. So this was a very quick review of specific genitourinary and renal disorders, also male disorders. If you have any questions, please feel free to contact me, nickray@suscc.edu. Thank you for listening.